Good evening, everyone. Today, our topic is vaccination in special groups. These are the set of patients in whom we are going to get troubled by selecting which vaccines, why vaccines, and when to start vaccines. Being registered as special groups in clinical practices, most of the time we will be managing the primary etiology, and vaccinations will be utilized for sake of prevention to prevent further deterioration. Which are these special groups? These special group comprises of patients who are immunocompromised, such as those who have primary immune deficiencies, secondary immune deficiencies, immunomodulated, that means those who have been given either immunoglobulins or you have given steroids, or immunosuppressed, that is those who were receiving chemotherapy, to some extent radiotherapy. Along with it, we are going to talk today about vaccination in pregnancy and also vaccination in lactating mothers and other subset of population where pediatricians contribute. Without further ado, I am Dr. Nitin Chawla. I am Chief of Pediatrics at KIMS Gachibowli, Hyderabad. And starting with the presentation, when we are managing a child in conditions such as nephrotic or such condition where there is acute asthma exacerbation, and we have kept the child on corticosteroids or other immunosuppressive therapy, and child is receiving more than 2 mg per kg per day of oral corticosteroid, that is if the child is 10 kg and we are giving 10-20 mg per day for more than 2 weeks, then they should not be receiving live vaccines until and unless steroid has been discontinued for 1 month. The reason behind this is HPA axis is suppressed, and child will lead to have a very bad adverse reaction, and the propagating vaccine will cause more harm than benefit. If there is lesser dose of steroid than 2 mg per kg per day, or it is through inhaled or topical therapy, then these vaccines are safe and effective, and they should be given age appropriately. Children on immunosuppressive therapy other than corticosteroid should also avoid live vaccine unless benefits outweigh the risk involved. When we talk about cancers, then cancer per se is a problem where there is malignancy or there is benign cancer. And cancer per se will be affecting the organ involved. The cancer will not affect immune functions. But when we want to treat cancer, we remove the immunity from the body so that the cancer medicines and other therapies will be of use. So we should not forget the basic principle that immune function is minimally affected in cancer, and they generally do not contribute. This I'm talking about solid organ related cancers, and they do not lead to immunocompromised state. Total immunoglobulin concentration, specific antibiotic concentration, which for the vaccine which children have already received, will be normal. Now, when chemotherapy is started, then there will be induced secondary immune deficiency. And when radiotherapy is given, then the effect on immune function will be very less as compared to chemotherapy, but still there will be some change, some immunodeficiency after radiotherapy as well. So, in such circumstances, patients who are aged more than 6 months and have treatment has been started on anti-B cell antibody or intensive chemotherapy, for them, only one vaccine is recommended, that is inactive influenza vaccine annually. Pneumococcal conjugate vaccine should be administered to newly diagnosed children with hematological or solid malignancies, and they should be and PPSV 23 should be administered to children who are aged more than 2 years, and at least if given, it should be given 8 weeks after PCV. This vaccination as a question should be utilized, and we should remember that managing vaccination, maintenance chemotherapy, and the duration of chemotherapy, the consolidation phase, and when we induce, these are important parameters when vaccines should be considered. And inactivated vaccine are recommended for immunocompetent children and those who are receiving maintenance chemotherapy. However, we should remember that Administration of any vaccine, if done during chemotherapy, or we are worried about our decision, that can be confirmed by doing protective antibody level against the specific virus or bacteria which we want to take into control. We should not give live viral vaccines during chemotherapy. And 3 months after cancer chemotherapy, patient can be vaccinated with inactivated vaccines and also with live vaccine for chickenpox and MMR as per schedule. Those patients who have received anti-B cell antibodies as treatment, in such cases, vaccination should be delayed by at least 6 months. This itself will help us to understand which kind of uh, drugs, like if the patient is on rituximab, you will wait for at least 6 months before you plan for vaccination. So these guidelines are very important for us to make a clinical decision. This chart is accessible in Purple Book. Go through it. The one point which is important over here is that we have discussed already is that though live vaccines are not recommended during chemotherapy, and we should be considering giving live vaccines only after 6 months in case of anti-B cell antibody related treatment, example rituximab, ofatumab, ublutuximab, and more than 3 months post chemotherapy, other than anti-B cell antibodies. In those patients who have asplenia or hyposplenia secondary to sickle cell disease or radiation therapy involving spleen, these patients will usually be affected with encapsulated bacteria. There is also another set of patient which due to trauma has emergency splenectomy. All these patients where spleen is getting affected will be more propensity to get infected with encapsulated organism. So pneumococcal, Hib, meningococcal, and typhoid vaccines are indicated if not completed, in addition to all routine vaccines. All live vaccine can safely be given to these patients. And emergency splenectomy patient ideally should get these vaccination 2 weeks after splenectomy, whereas in like for sake of an example, in tropical splenomegaly, if you're planning splenectomy, then you should be giving this vaccination 2 weeks prior to splenectomy for achieving superior immunological response. In patients who have congenital immunodeficiency, such as severe B cell immunodeficiency, X-linked A gamma globulinemia, live vaccines are contraindicated. Measles and varicella vaccine can be given but are ineffective due to concomitant immunoglobulin therapy. Dilution will factor and competition to the receptors will be there. Inactivated vaccines may be given, but they are also ineffective. In less severe B cell deficiencies such as IgA and IgG subclass deficiency, only OPV is contraindicated and other live vaccines can be given. In severe T cell immunodeficiencies, all the live vaccines are contraindicated and all vaccines are ineffective technically. In case patient has received BCG prior to diagnosis, then these patients are more prone for getting complications of disseminated BCG disease. In combined immunodeficiencies such as ataxia, telangiectasia, viscotaltis syndrome, DiGeorge syndrome, inactivated vaccines can be given, live vaccines are contraindicated. In complement deficiencies, pneumococcal, Hib, and meningococcal are indicated, and all the vaccines technically are safe to be given. In phagocyte defects such as CGD, only live bacterial vaccines are contraindicated, and rest all other vaccines can be safely and effectively given. This is one of the slide which is very important for general practitioner, where children with who have chronic diseases like cerebral palsy, diabetic ketoacidosis, or congenital hypothyroidism, or hepatitis leading autoimmune hepatitis, or acute renal injury, or chronic anemia patient, or anemia of chronic disease, or there is cardiac underlying cardiac defect, all these patients should be covered with abundant of vaccination so that they can mount a good immune response and can maintain their physiology. Live vaccines can safely be given in these children. Particular opinion on pneumococcal hepatitis A, varicella, influenza, and rotavirus vaccine as per age appropriate should be offered. Immunogenicity, efficacy, and duration of these vaccines maybe will be lower than the healthy children because these patients are fighting with one illness inside. Thus, their response against vaccination probably will be less, but still they this response is going to help them to tide over the crisis. Their levels can also be checked. If at all we are planning whether to give A and B boosters, we can check their antibody responses. It is important to know that hepatitis A vaccine in patient with liver disease or pertussis booster in stable neurological disease is of mainly benefit. And those patients who have cystic fibrosis, or those patients who are in ICU with the bad pneumonia and have a long stay in ICU, in these patients, it is a responsibility of clinician, pediatric intensivist, pediatric practitioner who is associated in treatment to recommend pneumococcal and annual influenza vaccines for contact as well as for the primary case. Some subset of children will have allergy to component of vaccines or vaccination itself. Because when you give vaccine, you're not only giving the medicine, you're also having stabilizers, buffers, preservatives, and sometimes antibiotic and residue from the manufacturing process. So make sure that you observe every child who come to your emergency, who come to your OPD for vaccination for 15 minutes after vaccination, and you should have abundant of resources, primarily adrenaline, oxygen, midazolam spray, antihistaminic, and steroid, diphenhydramine, and steroid in your OP area all the time. There are certain vaccines where influenza and yellow fever vaccines should be considered as contraindicated if patient is known allergic to egg. If you have got an information that patient has a history of any hypersensitivity, that JE vaccine should be given with a lot of caution. And children children who have serious hypersensitivity reaction or anaphylaxis to a particular vaccine should never receive it again. In any case, make sure that you watch this child for 15 minutes and you have all the important resuscitation and allergy related equipment on standby. We are going to cover that topic in upcoming presentations. Those children who have bleeding disorder or are on anticoagulants, they are at increased risk of bleeding from IM injection. When vaccines are recommended, and they should be given only through IM route, then preferably use 23 gauge needle or smaller needle. Try to give vaccination schedule as closer to complement factor to clotting factor replacement time. Do not give vaccine and apply firm pressure without rubbing so that you decrease the amount of injury. Alternatively, certain vaccine like Hib, IPV, and pneumococcal polysaccharide have been shown as equally efficacious. So, through subcutaneous route, you can choose subcutaneous route also in such vaccines. In acute illnesses which are severe, sometimes the clinician has to decline the vaccination, and there is nothing wrong in it, because considering fighting mechanism of the body against disease, and if the disease is severe to moderate, then we should let body fight against the disease and we can plan giving vaccination and mounting an immune response after some days. But if this disease is minor, then opportunity should not be missed, and such minor illnesses are milder URI, no distress, no no fever, no high grade fever, only diarrhea with no dehydration, or one or small episode of loose motion. These are the conditions where clinicians should not restrict giving vaccination. Sometime our gynae colleagues take our opinion on vaccinations. I have kept 4 5 slides on the same. The immunization in pregnancy is generally considers live vaccine as contraindicated. Yellow fever vaccine to be avoided until unless it is unavoidable, and measles, MMR, and chickenpox are contraindicated in pregnancy. And in case patient has taken these vaccine and and pregnancy has happened, then there is no research which says that the child should be terminated. The pregnancy should not be terminated inadvertently after taking these four vaccines. And there is no role that MMR, measles, and varicella cannot be given to the contacts of the pregnant woman, because these vaccines do not spread from vaccine to contacts. During pregnancy, all the inactivated vaccines can safely be given, and hepatitis B and influenza are of specific importance in pregnant women. Rabies vaccine should also be administered to pregnant women if indicated, and they are very safe. We have already covered the previous slides in last talks. I'm skipping those. Now, immunization during lactation is another aspect because we as pediatrician are handling child and this mother is lactating in first 6 months, technically till 2 years. And if at all the question comes, then inactivated vaccine, whether conjugate, toxoid, subunit vaccine, all are safe in breastfeeding women and they pose no harm to the babies. Live vaccines technically multiply in the body of the mother and they do not cause any harm as they are also generally not excreted in the breast milk. Rubella vaccine may be excreted in milk, but it will not infect the baby, or if at all it affect, there will be only mild asymptomatic infection. Only exception is yellow fever vaccine, where it can result in infantile meningoencephalitis, though it should be avoided. And uh, if it is mandatory to be given, then breastfeeding should be avoided for next 10 days of vaccination. In case a patient wants vaccination, that I'm visiting my in-laws or visiting my home, then make sure that you do not give subsequent dosage of vaccination um, 5 days or before. If the doses are given, if you have to choose minimum dosage, then 4 week and not 3 week, 3 days. So the dosage should not be given 4 or less day from the minimum interval. If inadvertently it has been given 5 or more days before the minimum interval, then that dose will not be counted. And if there is unknown immunization status, child should be considered unimmunized. Only two vaccines, that is PPSV23 and influenza, are considered that patient in absence of documentation, the self-reported doses will be accepted. Serological testing on research basis seems to be a valid way of understanding the status. Many of the children who go abroad have to take this test out of confusion. So ensure that whichsoever child you are vaccinating, you mention all the relevant information on their vaccination card and tell the parents that these vaccination schedules will be very important for you to help your child secure a seat when they want to go out of India to study. And this schedule will have a long way, and this schedule will be recognized by any university outside India, even in India. Catch a vaccine as a vaccination talk is scheduled in upcoming weeks, so we will not go in detail. Only thing which I want to tell is that vaccination catch up should be individualized. You can give same day live and inactivated together. Only distance of 5 centimeter maximum between different vaccines, if intramuscular is given, should be considered. Inactivated vaccine can be given anytime, and catch a vaccination should be done in at most in minimum possible interval so that early protection can be provided. When we talk about interchangeability of the brands, HIV, hepatitis B, and hepatitis A can safely be interchanged. Evidence says that DTAP should not be interchanged. But if you do not have a choice and there is no other brand available, then proceed with whatever is available with you. Do not cancel or miss the dose. When we are talking about vaccination in certain subset of patients who are receiving IVIG or who are receiving antibody containing products, then we should remember that blood, IVIG, plasma, these will inhibit immune response to live vaccines such as measles and rubella for next 3 months. And other live vaccines like typhoid or type 21A, rotavirus, yellow fever, zoster vaccines, they can be administered anytime, concurrent with administration of immunoglobulin or IVIG. Length of time with that interference with injectable live virus vaccine can persist after the antibody containing product, depending on the amount of antigen specific antibodies in that product. Thus, we may see a delayed passive immunity, but also that will be degraded. If a dose of injectable live virus vaccine other than yellow fever and zoster is administered after an antibody containing product, but this interval is shorter than recommended 3 month duration, then vaccine should be repeated. If you don't want to repeat the vaccine and you have a feasible lab reports of serological testing, then you can test the serological response to that organism for which live vaccine has been given, and decide accordingly further need of vaccine. When we talk about postpartum vaccination in women, there is no evidence of immunity to rubella or varicella with MMR or varicella vaccine that it should be delayed because of receipt of anti-RO globulin or any blood product during last trimester of pregnancy. These women should be vaccinated immediately after giving birth. If possible, should be tested later, 3 months later, for immunity against measles and rubella. If the interval between administration of any of the vaccine and subsequent administration of an antibody containing product is less than 14 days, vaccination should be repeated after the recommended interval unless you have serological testing feasibility. I'm skipping these slides because when you go through the talk, you will pause and you can read these slides. Most of the numbers will be deciphered and concept we are discussing already. When we talk about antibody containing product, inactivated vaccines, they will interact less with antibody containing product, and thus they can be simultaneously can be given with or at any interval, and they will not impair development of protective antibody response. Only thing to remember is toxoid and antibody preparation should be administered at different sites using the standard recommended dose. Increasing the vaccine dose volume or number of vaccination is not indicated or recommended. In the transplant recipient, hematopoietic stem cell transplant recipients, these will be like unimmunized as they have lost all the memory response during marrow ablation. So in these cases, vaccination requirement needs special consideration. There should be need of 3 doses of tetanus diphtheria containing vaccine, which should be administered 6 months. Am I audible to all of you? Sorry for the inconvenience. Yes, there was some technical issue, Dr. Poonam. Am I audible? So, transplant recipients, like we were discussing, 3 doses of pneumococcal vaccine should be administered to all the adults and children. And this should be given at least 3 to 6 months after hematopoietic stem cell transplantation. At 12 months after hematopoietic stem cell transplantation, 1 dose of PPSV 23 should be provided to the patient who does not have chronic graft versus host reaction and disease. For those who have graft versus host disease, a 4 dose of PCV can be given at 12 months after HSCT. 1 dose of influenza, inactivated influenza vaccine should be administered annually to all the persons who have aged 6 months, starting 6 months after HSCT and starting 4 months if at all there is a known outbreak in the community. For children who have aged 6 months to 8 years, because we have removed completely their memory cells, 2 doses of influenza need to be administered like we give it to an infant who comes to us for the first time influenza vaccination. 2 doses of meningococcal conjugate vaccines, Minecta-4, should be administered 6 to 12 months after HSCT. 3 doses of HPV vaccine 6 to 12 months after HSCT for female patients aged 11 to 26 should be considered if they are HSCT recipients. Live vaccine should not be administered to hematopoietic stem cell transplantation patient with active graft versus host disease or ongoing immunosuppression. We should remember that transplant recipient will be on some immunosuppression all the time. Live vaccines should not be given. Solid organ transplants are another subset of patient where we have to remember three important factors. First, immunosuppressive activity of underlying disease is in play. This will suppress their immune system. There is a rejection of organ graft. Thus, immunosuppressive therapy will be given after transplantation. These candidates who are waiting for transplantation should ideally be getting the should ideally be having more suppressed immune system after transplantation. Thus, many of the conditions for which patients undergo organ transplant are at least to some extent immunosuppressive, and thus vaccination should be considered early during the disease rather than after the transplant. And in general, standard vaccination series should be given to children who are waiting solid organ transplant, although we also can accelerate the schedule if needed. And when we plan transplant, then we should be planning live vaccines 2 weeks, mandatorily 2 weeks prior to transplant for have a better seroconversion. If we can document it, we should try to document the immunity which the patient has received. And the optimal time to begin vaccination administration after transplant is not defined. This is generally being administered according to the immunosuppressive therapy in play. So first couple of months there will be intensive immuno or chemotherapy, and these patients should not be getting any vaccination. All the live vaccines, because they are on some immunosuppressive therapy, are contraindicated, and inactivated vaccine should be given 6 months post transplant. Boosters for inactivated vaccine should be given as per schedule. If you can check titers, then better to check them. Annual influenza vaccination is highly recommended, and all the household and healthcare workers contact should be immunized against influenza and chickenpox as well, who will be taking care of these transplant recipients. This another subset of patient is very important. Those are immunocompromised. Now, these immunocompromised patient, in these patient, vaccination is rather safe as compared as we generally perceive. General principles in these patients are that all inactivated vaccine can be given, although their immunogenicity will be slightly low. In severe immunodeficiency, all live vaccines are contraindicated. In mild and moderate, live vaccines can be given, and that to give or not to give is dependent on how clinical decision um, is towards benefit, or if you see there are more risks, then you avoid them as well. If patients have administered live vaccine prior to diagnosis, then definitely you should watch for vaccine related adverse effects. If possible, check antibody titers after vaccination on regular basis, and boosters should be planned accordingly. If we are dealing and we have antibody titers, then we decide on those and number, and on how many times, at least for hepatitis B, we can check, plan, and give. For major or contaminated wound, tetanus immunoglobulin is required in addition to TT, even if more than 3 TT doses have been received in the past. For household contacts of immunocompromised patient, there is no need to worry about MMR or vaccine or varicella vaccine, but you cannot give OPV to them. Make sure that all the patients who are in contact with immunocompromised cases should be fully immunized for influenza and varicella to reduce the risk of transmission to immunocompromised person. Some vaccines such as pneumococcal, varicella, Hep A, inactivated influenza should be given if resources permit so that they have a better chance to fight against these infections. Another subset of patients who are now being managed with very robust uh, national programs are HIV. HIV patients are vulnerable to severe recurrent and unusual infection by vaccine preventable pathogens. The efficacy and safety of vaccine depends on degree of immunodeficiency. Generally, CD4 plus counts less than 200 cells per cubic millimeter is known to elicit minimal or no host response. And the better antibody response will wane at a faster rate in HIV infected person. Antiretroviral therapy improves immune response to vaccine, but not to the level of an uninfected subject. Thus, we should remember that effect will be there, but it will always be less. And live vaccines have an added enhanced risk for uncontrolled replication of virus strain. So, if you are giving vaccination, you should give it early and in effective in infancy before HIV infection causes immune suppression to severe level, and duration of protection may will get compromised with impairment of memory response with immune attrition. In older HIV-1 infected children and adults, immune response to primary vaccination will be less, but protective immunity to vaccine received prior to infection is usually maintained. However, the immunity for measles, tetanus, and Hep B will wane faster as compared to other antigens And also, we should remember that the protective response from attrition will also be there. So, whatever is we will be developed will be less as compared to the usual child. When we talk about live vaccines, all live vaccines are recommended in mild or moderate stage, except BCG and OPV. If patient is symptomatic, all the live vaccines are forbidden. Only in certain subset of patient, measles, MMR, and varicella for specialist consideration, and they can be given. Killed vaccine, they can be given easily. Only we should remember that the immune response mount will not be as in a non-infected child. We should remember that in a HIV infected child, there is multifold enhanced risk of diseases like Hep A, B, measles, tuberculosis, influenza, chickenpox, meningococcal, and pneumococcal, and thus use your knowledge judiciously and recommend all these vaccines to safeguard interest of your patients. This one slide have abundant of information on how to choose, what to choose, why to choose, and thus spend some time on this. Most important principle to remember in HIV patient is if the CD4 counts are more than 200, you may consider it as moderate and not severe immunocompromised state, and you can proceed with caution in live, and you can easily give killed vaccines. And if the number is less, no live vaccines. Inactivated influenza vaccine should always be considered. Influenza and varicella vaccines for contact should always be considered. Use nearly all the killed vaccine, conjugate vaccine, so that you can provide ample of opportunity to patient to fight against these infections. With this, I will conclude this presentation. And there is one question by Dr. Shubham. In planned splenectomy, should the vaccination be initiated 2 weeks prior or completed 2 weeks prior? So it should be done 2 weeks prior to surgery so that the body can generate some immune response. After splenectomy is done, it will take it should be done after 2 weeks. I will not be taking any questions, and if at all there are any questions, we will be taking on the group. So feel free to